Welcome everyone to this PCR webinar on vasomotor disorders in epicardial vessels or the microcirculation. My name is Vijay Kanadian. I'm an academic interventional cardiologist based in Newcastle upon Tyne, United Kingdom. It's my great pleasure that we are joined today by Professor Filippo Crea, interventional cardiologist, Rome, Italy, and who's also our editor-in-chief of European Heart Journal. We're also really delighted to have Dr. Peter Ong, interventional cardiologist from Stuttgart, Germany. So the learning objectives of this webinar are as follows: to understand what causes vasomotor disorders affecting the microcirculation and or the epicardial vessels, to learn how to diagnose vasomotor disorders in the cath labs, to review practical aspects and pitfalls of acetylcholine testing in the cardiac catheterization laboratory. So one might ask, does microcirculatory dysfunction really matter? But of course, in the interventional world, we are often focused on the epicardial vessels, and we're extremely good at fixing them with the stents that we have. But does coronary microcirculatory dysfunction really matter? Absolutely, yes. And that's one of the reasons why we went ahead to put together this expert consensus on ischemia with non-obstructive coronary arteries in collaboration with the European Society of Cardiology Working Group on Coronary Pathophysiology and Microcirculation, and also in collaboration with our colleagues from the COVADIS group. And this consensus document has been published simultaneously in Eurointervention and European Heart Journal. And we provided several recommendations with regards to INOCA. And as I have shown here, INOCA should be recognized as a clinical entity in daily practice. And there should be a systematic approach to diagnose and treat these patients. So we get the diagnosis right for these patients, and so we provide the right treatment. And it's not just one individual's job. It's a collective effort from national and international scientific societies. We do further work in order to understand the pathophysiology. So we provided targeted pharmacotherapy for our patients. And more importantly, a lot of the time, the diagnosis is often missed and the patients are not given the right treatment because of lack of awareness of the condition. Given we are focused on the epicardial vessel, the microvasculature often gets forgotten. And that is one of our aims. And we're very grateful for PCR as well as for the sponsors for organizing these series of webinars in order to create awareness as well as to provide education on INOCA. So the INOCA endotypes consists of epicardial vasospastic angina, microvascular angina, and of course, patients can have both microvascular and epicardial vasospastic angina. So again, the question of, so what? Fine, a patient has got microvascular dysfunction, so what? And the problem here, as I've mentioned already, is that it's rarely very correctly diagnosed and often leads to misdiagnosis for our patients. And as a result, patients are not receiving the appropriate tailored therapy. And that leads to patients experiencing recurrent angina and leads to impaired quality of life. And if they have recurrence of symptoms, then of course they're going to come to the doctors or with repeat hospitalization and undergo repeat procedures. And more importantly, as Professor Crea will mention to us, patients with INOCA do experience adverse cardiovascular events in the short and the long term. And often we see with these patients is that even the clinicians themselves can say to the patients, there's probably nothing wrong with you. And we have provided a clear algorithm, both for non-invasive as well as for invasive assessment of patients with INOCA. For the purpose of this webinar today, I know many of you would have attended the other webinars that we have gone through the detailed invasive assessment. We will be focusing on the vasoreactivity, in particular acetylcholine. And we know that this is not commonly utilized by everyone across the board. And we're going to spend some time looking into that in great detail. So with that in the background, I would now like to invite Peter to present the cases of microvascular spasm.
EJ, thank you very much. Hello from Stuttgart in Germany, and welcome. As this is a practical webinar, I would like to illustrate this vasomotor disorder field with two cases. The first case, as you can see here, is a 73-year-old female patient with repetitive attacks of resting angina associated with nausea and palpitations. The patient has a normal LV function, and her only cardiovascular risk factor is hypercholesterolemia. The patient has had a diagnostic angiogram without epicardial stenosis, as you can see in the next slide. There's a still frames of the left and right coronary artery. You can see that the vessels, especially on the left coronary artery, are quite curly. And you can also appreciate that the left ventricle has a normal function. So to further investigate the cause of the patient's symptoms, we went on and performed acetylcholine provocation testing. You can see here on the left-hand side, the left coronary artery after 100 microgram of acetylcholine. And on the right-hand side, you can see the left artery after nitroglycerin. So perhaps you wonder whether there is a change in the epicardial diameter, especially on the LAD. There may be on the left-hand side a bit of vasoconstriction, but there was no epicardial spasm. However, the patient during the testing said that she had the same symptoms that she had experienced before. And you can see here that during acetylcholine, there were quite marked ST segment depressions, as shown here by the right arrows on the left-hand side. And after nitroglycerin, these ST segment changes were not seen any longer. So this led us to the diagnosis of coronary microvascular spasm. I would continue with the second case. The second case is a case of post-PCI angina. It's a 77-year-old male patient. The symptoms are predominantly on exertion. He has also accompanying dyspnea. His risk factors are hypertension, former smoker, and a positive family history. The LDL is well controlled with a quite high dose of atorvastatin. He has had several PCIs in the past, and the cardiac MRI and the scintigraphy at the moment, they do not show any relevant ischemia. However, the patient presents with angina refractory to several anti-anginal medications, and you can see the current medication at the bottom of the slide. So the patient presented to our center, and we decided to perform another angiogram in search of coronary spasm. This is the left coronary artery. There was no instant restenosis and also no other epicardial stenosis that was important for us. And then we went on to the right coronary artery, where you can now see the images on the left-hand side. This is the diagnostic angiogram of the right artery. And I think most of us would have said this is no epicardial stenosis. There's no instant restenosis. So what should we do? But on the right-hand side, you can now see the right artery after 80 micrograms of acetylcholine. And the patient had diffuse coronary spasm, especially in the distal branches of the RCA. You can also see the vasoconstriction between the two stents in the proximal part. The patient had reproduction of his usual symptoms during acetylcholine testing. And you can also see that there was significant ST segment depression in the inferior leads, indicative of myocardial ischemia, whereas during the diagnostic angiogram on the left-hand side, there were no such changes seen. And this led us to the diagnosis of diffuse epicardial spasm post-PCI. as a frequent reason of post-PCI angina. Thank you, and back to you, Vijay.
Thank you very much, Peter. Really, two excellent cases that just set the stage for the rest of our webinar. I would like to emphasize at this point that we really want to take as many questions from the audience as possible. So please feel free to use the question function on the to put any questions to us, and we will try our best to answer. But for now, we will ask you this question. For coronary spasm assessment, do you use acetylcholine in your cath labs? There are four options we have. Yes, we use acetylcholine in our cath labs. No, acetylcholine not available. We'll use acetylcholine if available. Fourth option is not comfortable to use acetylcholine. So I believe the audience have 30 seconds to cast your vote. And of course, we will discuss the results once we have them. While we're waiting for the audience to put a poll to cast their vote on the question we have, I do have a question from one of our audience. And their question is, how can we infer vasospastic response to acetylcholine as diagnostic of vasospastic angina or a vasomotor disorder in the normal pathophysiological setting? So we could probably briefly answer that question, or probably we could answer that once we have covered the rest of our presentation.
Well, I think one of the important questions is what brings the patient to the cath lab. And usually patients are referred to the cath lab because the cardiologist is convinced that the symptoms are due to some form of coronary artery disease, and whether or not non-invasive ischemia testing is performed up front, the indication for the angiography is the symptomatic patient. And the production of the daily symptoms during the acetylcholine testing is a very strong component that leads us to the conclusion that the reproduction during the acetylcholine is sort of like the same situation that the patient has during daily life. But if the patient has no symptoms at all, then acetylcholine may elicit some form of vasoconstriction that has not any pathophysiological meaning.
Okay, thank you, Peter. I believe I do have the results of the poll now. 27% of our audience said that they use acetylcholine in their cath labs. 36% acetylcholine not available. 22% will use acetylcholine if available. 15% not comfortable. Let's see if we can convince our 15% of audience who are not comfortable with acetylcholine with the rest of our webinar. I will now invite Professor Kriya to provide his discussion on vasomotor disorders in the epicardial vessels and the microcirculation. Professor Kriya.
Thank you, Vijay, for your kind invitation to this interesting webinar, and let's hope that it will be useful for our colleagues. And you know, when we come to ischemic heart disease, I think that we have to reconsider the complex mechanism responsible for ischemia. This is a reappraisal of ischemic heart disease I published 2 years ago with Juan Carlos Kasky, Bernie Gersh, and Paolo Camici. And we say, okay, stenosis are important, definitely. We know that very well. But there are other mechanisms which can cause ischemia, and they are equally important, not less or more important, equally important. We can have epicardial spasm, and we can have microvascular dysfunction, which can be caused by structural mechanisms, by functional mechanisms, and also by myocardial factors affecting microvascular function. And this is why when we come to chronic coronary syndromes, we can have three different and possibly overlapping presentations. We can have stable angina caused by obstructive stenosis. We can have vasospastic angina caused by hyperreactivity of smooth muscle cells to constrictor stimuli. And then we can have microvascular angina. And here the mechanism is slightly more complex because we can have, on the one hand, hyperreactivity of smooth muscle cells to constrictor stimuli, but also impaired metabolic dilation. Let's start with vasospastic angina. Well, has been shown very clearly by Peter Hong. This is the hallmark of vasospastic angina. This is a patient with no obstructive atherosclerosis, and during acetylcholine testing, you can see in this case double spasm of distal LAD and spasm of the circumflex, associated to severe chest pain and ST depression, as you can see, and after nitrates, the spasm is relieved. And then we have microvascular angina. This is the other second or third presentation. And in this case, we have two possible mechanisms of ischemia. One is microvascular spasm. Again, hyperactivity of smooth muscle cells to constrictor stimuli, but in this case, not in the epicardial vessels, but in microcirculation. And in order to make diagnosis, again, acetylcholine is useful. If you inject acetylcholine in these patients, what you see is lack of epicardial spasm, yet the patient develops ST depression, ischemic ECG changes, and his or her usual daily chest pain, which is relieved by nitrates. But also metabolic dilation can be impaired. And in this case, what we see is a reduction of coronary flow reserve. In this case, it's like the stenosis, but the stenosis is not in epicardial vessels, but is in microcirculation and is related to a limited, reduced ability of microcirculation to dilate in response to an increase in oxygen demand. In both cases, epicardial stenosis or impaired microvascular dilation, the result is a reduction of coronary flow reserve, which in daily practice can be evoked by the same test we use to evoke ischemia in the presence of an epicardial stenosis. This is a lady, no obstructive atherosclerosis, baseline ECG is fine, and during adenosine testing, well, severe chest pain and severe ischemic ECG changes. This is what we see in a patient with an epicardial stenosis. Again, the stenosis here is not epicardial, but is in microcirculation. Now, the question is, and I think these are now three relevant points, why to bother about functional coronary alterations? Well, I think that we should bother for three important reasons. First, the prevalence of functional alterations is much more than we thought before, and has been put and kept under the carpet for years and decades. Now, this is a study from the States, Manish Patel, large population of patients with suspected angina. And you can see in particular those patients with typical angina and those patients with not only typical angina, but also positive stress test. On the ordinate, you can see the prevalence of obstructive atherosclerosis. Well, this was 50% only. This means that in this unselected population of patients with typical angina and positive stress test, ischemia in 50% of patients was not caused by obstructive atherosclerosis, but by functional alterations. So this is the first important point. It's not a rare syndrome. It's frequent. Functional alterations explain angina in up to 50% of patients with typical angina and positive stress test. The other reason to consider these functional alterations of coronary circulation is that the outcome is not so good as we thought before. This is a study from Denmark. You can see patients with control patients with a good outcome. And these are patients with angina, but normal coronary arteries, angiographically normal coronary arteries. And here you have patients with subcritical stenosis and patients with 1, 2, and 3 vessel disease. This means that the outcome of these patients with angina and no obstructive atherosclerosis is more similar to that of patients with obstructive atherosclerosis rather than patients without controlled patients. And on the other side of the ocean, this is a study from Boston by Viviani Tacchetti, an excellent study carried out by PET, which is, as you know, able to assess non-invasively and accurately coronary flow reserve. And this is a population of patients with angina and no obstructive atherosclerosis. And you can see that both in men and women, the prevalence, the outcome, the rate of major cardiovascular events is much higher in men and women with reduced coronary flow reserve as compared to those with normal coronary flow reserve. So the outcome is not as good as we thought before. And when we come to treatment, this is an issue frequently raised, but okay, we find dysfunctional alterations, but what about treatment? Well, this is a very interesting and early study, the Cormica study published by Colin Berry and this group. This is a population of 300 patients with suspected angina. Not surprisingly, 50% of these patients had angina but no obstructive atherosclerosis. But what they did here was to randomize patients to intervention where treatment was guided by functional assessment of coronary circulation, and the control group where treatment was simply guided by angiography. And on the right of the slide, you can see that the quality of life and angina was better in patients in whom treatment was guided by coronary functional assessment. So this is the third reason why we have to identify these patients. They are frequent, the outcome is guarded, and the treatment can be improved by the knowledge of the precise mechanism of myocardial ischemia. And I think that in this new perspective of ischemic heart disease, the cath lab acquires a central role, because only in the cath lab it is possible to assess all functional alterations of coronary circulation. It's not possible by non-invasive coronary angiography. It's not possible by PET. It's not possible by cardiac magnetic resonance. If we want to investigate all functional alterations, all possible mechanisms of ischemia in a patient with suspected angina, the only place where we can do it is the cath lab. But we have to use properly our tools. And this is what we propose in this recent paper we published as COVADIS. COVADIS is an international, it's a global task force for the study of functional alterations of myocardial ischemia. And Peter and me are member of this COVADIS group. So what we propose here is, okay, let's start with coronary angiography with contrast, and we can find obstructive atherosclerosis or myocardial bridging. Of course, we have to rule out obstructive atherosclerosis. If obstructive atherosclerosis is ruled out, well, we can measure coronary flow reserve, which can be found to be abnormal, less than 2, or we can measure microvascular resistance, which can be found to be abnormal, IMR more than 25. Well, if we find a reduced coronary flow reserve, this means that the mechanism of ischemia, at least one mechanism of ischemia in this patient, is a stenosis, but not in epicardial vessels, but in microcirculation. If these values are normal, then we can proceed with acetylcholine testing, which can evoke, as we have seen with Peter's presentation and also in my presentation, can evoke epicardial spasm or microvascular spasm. Now, if we have spasm, well, we know that the mechanism of ischemia in these patients is an abnormal reactivity of smooth muscle cells to constrictor stimuli. So the cause is spasm, epicardial or microvascular. Well, it is possible that in spite of suspected angina, we find no stenosis, no reduction of coronary flow reserve, no spasm. Well, in this case, this means that the pain in this particular patient is not of ischemic origin, which I think is important, because if the pain is not of ischemic origin, we want to know it, because we can tell the patient, well, go somewhere else, because as cardiologists, we can tell you that your pain is not of cardiac origin, but we can rule out the ischemic origin of pain only going through this sequence of diagnostic investigations. Because if we tell the patient your pain doesn't come from the heart, because we do not fully investigate his pain, we give the patient the wrong advice. And some of these patients go to the psychiatrist because nobody is going to identify the cause of his ischemic pain. And again, with this approach allows to identify a microvascular angina, vasospastic angina, or obstructive epicardial coronary disease, as we have defined here and as defined before in the previous presentations. And this is an example of vasospastic angina, no obstructive atherosclerosis, normal coronary flow reserve, but epicardial spasm in this case. And this is an example of microvascular angina, no stenosis, no spasm, but reduced vasodilation, metabolic vasodilation, reduced coronary flow reserve. And very short comment on the important thing Peter said before, because these functional alterations not only are present in patients with microvascular angina, vasospastic angina, but can also be present in patients with epicardial stenosis. And in this case, the functional alterations are revealed, are unmasked by stenting, because if we remove epicardial stenosis with stenting and the patient keeps presenting angina, well, this means that the stenosis probably was not the cause of these symptoms. Now, the prevalence of persistent or recurrent angina after stenting is not trivial. These are well-known studies, and in these well-known studies from Courage to Arts and others, the prevalence of post-PCI angina was between 20 and 40%, 20 and 30%. So up to 1/3 of patients, in spite of stenting, presents recurrent and persistent angina, probably because functional alterations are present and unmasked by a successful PCI. And this is why in these patients also, when the patient comes back complaining of persistent angina, and we found no obstructive atherosclerosis, of course, we have to investigate obstructive atherosclerosis. This patient can have in-stent restenosis or obstructive atherosclerosis, which was noticed the first time, or progression of atherosclerosis in epicardial vessels. Of course, we have to rule out structural causes of this recurrent angina. But if these structural causes are not there, if can be excluded, then if the patient presents persistent angina, again, up to 1/3 of patients after PCI, in order to rule out an ischemic origin of the pain, we have to go for a functional assessment of coronary circulation. And we are not discovering anything new. Long ago, William Osler wrote very wisely, the good physician treats the disease, the great physician treats the patient. In our setting, we can say the good physician treats stenosis, the great physician treats the coronary circulation. Thank you.
Thank you very much, Professor Crea. So beautifully put. And I really liked what you said. This condition has been put under the carpet for a very long time. We no longer want it to be in that same way. And I also loved what you said. Great physician treats the patient, and in our case, treats the microcirculation in addition to the epicardial circulation. We are now beginning to get quite a lot of questions from our audience, and I, in fact, put together a question as a preparation for the webinar. If I can bring the question up on the screen, please. Okay, so it looks like we've skipped the question. Anyway, one of the questions that I have from the audience is that what complication might be faced during acetylcholine, and how should they be managed? Is there any tips from the experts? So I think that's exactly what you're going to talk about just now, Peter. So I'm going to hand over to you. And after your presentation, we will answer the many questions that we're receiving from our audience.
Thank you very much, Vijay. We will continue with the practical part. For those of you who would like to start performing acetylcholine testing in the cath lab, just to remind you that we are backed up by the 2019 European Society of Cardiology guidelines on the management of chronic coronary syndrome, where you can find acetylcholine testing as a class 2A indication in patients with non-obstructive lesions or normal arteries to diagnose the site and mode of spasm. When we talk about the safety of spasm testing, just as one of the questions was posed, then you can see here that many thousands of tests were performed over the years, and the rate of complications is rather low. And we always say that this is in the range of the complications that you can get for diagnostic coronary angiography. And you can see that different studies use different definitions of complications, but overall, the rate of complications was very, very low. Another important aspect when using acetylcholine for spasm provocation testing is to differentiate between complications and side effects. As shown in this paper, there are transient side effects frequently occurring during acetylcholine testing, such as AV block or sinus bradycardia, ventricular ectopic beats, or hypotension less than 90 millimeters of mercury. However, these are only transient effects and so-called side effects, but not real complications. And in this study, comparing INOCA patients with stable angina patients, the only transient complication observed was paroxysmal atrial fibrillation. I think it's quite important when using acetylcholine to remember that the real complications are even lower than previously reported. I also think that it is useful to use acetylcholine testing in the cath lab because the yield of an abnormal test result lies around 60%, as shown in this study from a couple of years ago from our group. So there's a quite high yield in finding an vasomotor disorder. And this, of course, as we have seen, has an important implication on patient management. So when we now come to the evaluation of the patients in the cath lab, of course, it is often not part of routine assessment, but in my opinion, it is easy to add after diagnostic angiography. It needs a 12-lead ECG, but no guiding catheter, and the solutions can be prepared by the cath lab nurses. In some centers, it is a standard procedure in all patients with unobstructed coronary arteries. And I can show you right now that the criteria for the interpretation of the test result are threefold, comprising symptoms, ECG changes, and spasm on angiography. This brings us to the definition of epicardial spasm, which contains these three components: reproduction of the symptoms, ischemic ECG shifts on the 12-lead ECG, and an epicardial vasoconstriction of more than 90%. Microvascular spasm is defined similarly, but without epicardial spasm of 90% vasoconstriction. Here is an image where you can see that the cath lab nurses in our lab, they are well trained to prepare the solutions themselves. We have an SOP with a step-by-step explanation, and all cath lab staff are capable to perform these preparations. It is also important to have a 12-lead ECG with radiolucent electrodes. And coming now to the real practical issues, if possible, a radial cocktail should be avoided, but it is of course allowed. Diagnostic angiography should show no epicardial stenosis. And we always start with the left coronary artery because two vessels can be challenged at the same time. An RA or caudal projection is usually best for assessing epicardial spasm in the LAD and the circumflex artery because this is the best view. You can see that we are using this protocol at the moment with escalating doses of 2, 20, 100, and 200 micrograms in the left coronary artery. And we always monitor the ECG and the patient's symptoms, as well as any epicardial spasm during the angiography. Here you can see how we do it. We look at the ECG, we look at the angiographic response, and we interact with the patient. So my tips and tricks for you are that you should always check that the catheter is fully engaged in the coronary artery, because otherwise the acetylcholine will be injected into the aorta without any reaction on the coronary arteries. You should always not forget to flush after the injection with saline in the same speed, because otherwise you will get a bolus injection. The continuous interaction with the patient is essential, and nitroglycerin is the important medication to relieve spasm. And if that does not help, then you should inject atropine intravenously, because that is the direct antagonist, and this will always resolve any prolonged spasm. If bradycardia occurs, then slow down or pause the manual injection, and the heart rhythm will come back immediately. And in the rare instances where you have atrial fibrillation, then inject nitroglycerin and wait for sinus rhythm to come back. It sometimes takes maybe 1 or 2 hours, but I've never seen a patient with persistent atrial fibrillation after acetylcholine testing. As already mentioned, this is part of the invasive diagnostic procedure with the adenosine assessment and the respective wire, but that is not part of today's webinar. Thank you very much, and I hope we have time to take questions.
Okay, thank you very much, Peter. That was a very clear explanation of how to set up and use acetylcholine in the cath lab. So as we saw in our poll, up to 20% of colleagues are not comfortable using acetylcholine. So what are the challenges in, so you have been using this in your laboratory for many years now. What are the challenges in setting acetylcholine in terms of practical applications? And people do have fears, and you have very clearly shown that the complication rates are very minimal. So again, one of our goals for this webinar is to convince and also to adopt what's been mentioned in the CCS guidelines. So how would you convince those 20% of colleagues who are not comfortable using acetylcholine?
Well,
yeah, please.
No, please, Peter, go first. Go first, please.
The short answer is seeing is believing. So as shown in the cases, especially in the second case, I think nobody would have expected such severe spasm in this completely dilated right coronary artery. So seeing is believing. And two important things for setting it up. One is access, to be able to purchase acetylcholine, which can be difficult. And the second is to start with this protocol where you have a stepwise approach with low dose and then going up to the higher dose. And if you do this, then there is no issue in terms of safety, and you will see that it's a benefit for the patient. Filippo.
Well, I would start asking ourselves, who is a doctor? What is our job? What is our duty towards our patients? If our goal, our duty is to make, when we have a patient in front of us, an accurate diagnosis, we have to put ourselves in the best position to make a correct diagnosis. And this is what we are facing here. We know that in 50% of patients with suspected angina and evidence of ischemia, in 50% of these patients, we do not find obstructive atherosclerosis. So the good doctor asks himself, okay, if we do not have stenosis here, can we identify other causes which can explain the symptoms of these patients? Well, if I ask myself this question, then I carry on with what we said before: assessment of flow reserve, ischemia, microvascular resistance, acetylcholine. I mean, we have a full armamentarium. So the reaction to this patient in front of us with angina, and sometimes these patients are desperate with severe angina, but no stenosis, we can tell the patient, well, listen, it's not my business, because my business is to rule out stenosis. You don't have stenosis, so your case doesn't belong any longer to my area of expertise. This can be a reaction, and this is what frequently is done by our colleagues, by our cardiologists. The second possibility is to tell the patient, listen, you have this pain, we have evidence of ischemia, we don't find stenosis, we need some extra effort in terms of investigations to establish whether your pain comes from the heart, and in this case, why it comes from the heart, what are the mechanisms, or perhaps your pain looks like cardiac, but is a false positive, it's not cardiac, and then you have to go for other cause. It can be esophageal spasm, or can be another disease. Now, if we accept the challenge, if we have in front of us a patient who is suffering, and we want to establish why he's suffering, and we don't find stenosis, then the option we have is to go for these additional investigations, which are not so time-consuming, because measuring coronary flow reserve and acetylcholine testing is much quicker than stenting a patient. So I think that we have in front of us procedures which are safe, as clearly shown by Peter, are not expensive, do not consume so much extra time. And after this full investigation, we can tell our patient, well, I know I am a good doctor because I didn't find stenosis, but I identified what is the mechanism of your angina, and I can treat you accordingly. And I can tell you that based on my experience of many years now, when where I go on and ask myself, okay, what is the problem in this patient? And I find the cause of ischemia, well, the treatment of these patients become very efficient. And I make you a very simple example, which happens to me frequently. The patient comes with chest pain, and acetylcholine is positive, showing an epicardial spasm. Then I started giving verapamil, 80 milligrams twice a day, and the patient still is symptomatic. Then I increased 3 times a day. The patient perhaps improved 80 milligrams TDS, and the patient perhaps improves, but is not happy. And it happens that they have to go up to 4 or 5 tablets per day, or perhaps adding amlodipine or another calcium antagonist, and eventually the patient becomes asymptomatic, and it tells me, well, now I'm fine, I can go back to my normal life. Now, you push your luck with higher doses of calcium antagonists, with a more intensive treatment, if you're confident, if you have the diagnosis, and then you know that that is the way to go. You can push your luck because you know that you are doing the right thing. But I wouldn't dare to push my luck in terms of treatment, not having an accurate diagnosis. This is why it's so important to have clear ideas about the mechanism of pain in a patient who presents typical angina and a positive stress test.
Yeah, absolutely. One of the, again, through the pre-webinar question that we put through, in the United States, I believe only 10 centers use acetylcholine. And on the other hand, in Japan, it is a routine, it's in the routine protocol and in their guidelines. So again, just to help our audience, where is the obstacle? Is it the pharmacy? Of course, as interventions, we inject all sorts of things into the coronary arteries: adenosine, streptokinase, tenecteplase, you name it, to improve the no reflow, etc. And we are capable of handling the arrhythmias and everything that we see. And from what, Peter, you have shown, is that the complication rate with the acetylcholine is not that great. So when you, for example, in Germany, when you started doing it, where were the barriers? Was it the lack of availability in terms of pharmacy not providing it, or was it the operators not happy to use it?
Yeah, the main problem was that the operators were not happy to use it because they were afraid of any complications that were not manageable. And I remember several years ago having a poster presentation at the ACC conference in the United States showing our complication rate of acetylcholine testing. And one of the judges at the poster said to me, "What happens if the left main goes down?" So they were afraid of left main spasm and serious complications, because anecdotally there were case reports saying this eventually happened in a patient. I don't know, but we have now done more than 6,000 tests in Stuttgart, and we never saw left main spasm, not in a single patient. And we also do proctoring at centers in throughout Europe, where colleagues say, "Look, we want to start doing this. We are convinced that this is useful, but please help us to get it going." And I think this is an important step, that you have an experienced person in your lab, you can do it yourself, and then you get the tips and tricks hands-on, and this then is an important way how to get it started. So seeing is believing, and don't be afraid if you use the stepwise approach, and contact us if you need any help. We have a network now of a lot of centers who do it, and then you will see that it is useful.
So again, there is another question which has come up. Have you seen ST elevation with acetylcholine? And you mentioned during your talk that give nitroglycerin. And I'm assuming nitroglycerin should just be sufficient to reverse that. And if not, you also mentioned that atropine can be used.
Yes, that's right. So, of course, acetylcholine testing can also elicit occlusive spasm, which is sometimes called Prince metal variant angina. So ST elevation and focal occlusive spasm, that is approximately 10 to 15% of the cases that we do. And also in these cases, nitro is very efficient in relieving this occlusive spasm with ST elevation. And if that doesn't work, then atropine is the drug of choice. That is independent of the type of spasm, either focal or diffuse. Yeah,
great. So that's quite reassuring, and hopefully alleviate some of the concerns that people have with the use of acetylcholine. One more question I think we have time for, and several people have asked that. How about ergonovin?
Well, ergonovin was used in the past, mainly in Japan, but also to some extent in Europe. Ergonovin, we have a large experience with ergonovin in the assessment of epicardial spasm, and the results are similar to a large extent with those we see with acetylcholine. But we have much less experience with ergonovin when we come to coronary microcirculation. So in order to simplify what can be simplified, it's better to stick to acetylcholine this day, because thanks also to the contribution from the Peter Oaks group, we have really a large experience, and also many studies from Japan, large experience with acetylcholine, both in the assessment of epicardial spasm and microvascular spasm. I think it's better it's simpler to stick to just one agent, which has been widely used in the last year. Ergonovin probably, at least in epicardial vessel, can give similar results, but it's simpler to use just one agent to investigate both epicardial spasm and microvascular spasm. And, coming back to your question, but why is it not used? I think that major responsibilities in our guidelines, because in guidelines, indication for acetylcholine testing in suspected vasospastic angina is 2A. Is not indication 1, but is a recommendation 2A. And when we come to microvascular angina, recommendation is 2B. I think that our guidelines should give a stronger indication. And also, if you read the current guidelines, which are excellent, they work very well. But a weak point I can perhaps identify is that they suggest 3 different pathways in patients with suspected obstructive atherosclerosis. Then they suggest an algorithm, diagnostic algorithm for patients with suspected obstructive atherosclerosis. Then they suggest another pathway, another flowchart for patients with suspected vasospastic angina, and a third approach for patients with suspected microvascular angina. Well, in the European Heart Journal, I published a viewpoint entitled, "Doctor, I feel microvascular angina." Well, the problem is that the patient doesn't come to us telling, I feel stenotic angina, I feel microvascular angina, I feel vasospastic angina. The patient comes to us complaining of chest pain, which might be of ischemic origin. So in the guidelines, to propose these 3 different pathways doesn't fit with our clinical practice, where we see patients without any label on the front, but with chest pain. And I think that we need a comprehensive diagnostic flowchart in order to investigate not stenotic, microvascular, or vasospastic angina, but to investigate the patient complaining of chest pain. So I hope that in the next guidelines, a common path will be proposed for all patients coming with suspected angina, a common path which will include acetylcholine as recommendation 1 and not 2A or 2B. So in order to make a step forward, we have to win the psychological barrier of some colleagues who prefer to make diagnosis of stenosis rather than of angina. And also, more equally important, we should seriously change our guidelines.
Thank you very much. Peter, very briefly, there is again a recurrent question coming up. Bolus or infusion? I know that you've touched on it in your presentation, but for the sake of our audience, if you could emphasize that again, please, based on your practice.
Yeah, manual injection is easier, but you can also use continuous infusion with the infusion pump. Both is possible, both is feasible, but it's easier to do manual injection. Okay.
Thank you very much. I really do hope that we have been able to convince everyone the importance of just taking one step further in evaluating our patients. And that primarily comes down to this fact that we want to provide our patients with the right treatment. And again, we provided the management algorithm very clearly in our consensus document. For vasospastic angina, the drugs of choice are calcium channel blocker, long-acting nitrates, and nicorandil. And it's also important to emphasize that at least in where I live and practice, patients do have atherosclerosis on top of spasm. And it's really important that these patients are also considered for other agents such as ACE inhibitors and statin to help them prevent the progression of atherosclerotic disease, as well as treating their vasospastic angina. In this slide, again, you can find this in our consensus. We provide the details of the treatment that we can provide for our patients. And strongly, at least in my practice, I start with amlodipine, and some patients, of course, with verapamil or diltiazem, based on whichever they tolerate. And long-acting agents such as nitrate and nicorandil at a dosage of 10 to 20 milligrams twice daily. And of course, if patients have microvascular angina, in addition to that, then you would consider the other agents as we have shown here. So again, the key messages, and I think we really had a fantastic discussion, and very stimulating and encouraging, that it's about time that we really take our initiatives to take that one step further to evaluate our patients further. And again, I'm emphasizing the key messages here that we have again presented in our consensus document. It's really important to think about the condition. As Professor Kriya mentioned before, we used to put this under the carpet. And if you look at the statistics, cardiovascular disease is the leading cause of death worldwide, both for men and women. And if we don't treat conditions such as this, which happens in so many of our patients, we are going to see the adverse outcomes. So it's thinking about it. And sometimes we even encourage our patients. I know there are many patient groups that have come together now addressing these sort of problems. Even patients can ask, if perhaps the physicians are not, then could this be microvascular problem? Could this be spasm? And of course, follow the algorithm of initiating the appropriate diagnostic therapy. And in our consensus, we mention about non-invasive strategy, whichever you feel best. And again, as we have emphasized throughout this webinar, you really can't make a diagnosis without taking these patients, at least for now, without taking them to the cath lab for your microvascular assessment, as well as for the pharmacological coronary reactivity testing, so that we can provide the appropriate therapy for our patients. And more importantly, we're beginning to learn a lot about this condition, and of course, a lot of investment is needed into researching these conditions further, so we can continue to make progress for our patients, as well as in the global management of heart disease burden. So the therapy, the stratified therapy, will be extensively covered in the remaining 2 webinars addressing INOCA. So please be sure to join in for that, which is to be held on the 23rd of March. And our final webinar will be on INOCA in specific scenarios, which will be held on the 20th of April. So I would now like to take the opportunity to thank Professor Kriya and Professor Dr. Ong for taking your valuable time to join this very exciting webinar and for sharing your insights. So maybe you can give your final word to our audience. I shall hand it over to the 2 of you.
Well, I wish to thank you for this opportunity. And let's hope that asking again the same question, the poll, next time will be different results. We look forward to receiving new results from this poll next time.
Yeah, of course.
Yeah, I would also like to thank the organizers and you, Vijay, for the excellent moderation of the whole webinar. And my final statement is that acetylcholine testing in the cath lab is possible. The nurses and the operators can be convinced that it is useful. and it will prevent you from having patients coming back again and again for diagnostic procedures with unobstructed arteries. So these frequent flyers, as they sometimes called, they will not be coming back again because you have the diagnosis and you can start the right treatment. Thank you.
Absolutely. Thank you very much once again to everyone, and I wish you everyone a wonderful evening. Thank you.
Thank you. Bye-bye.
Thank you. See you.